In this lecture, we will discuss some details of chest pain as part of a series for cardiology for medical students. Chest pain is the most common symptom with which heart disease is associated. But all chest pain may not be due to heart disease. The characteristics of chest pain are important in differentiating the causes. History is most important and often the only tool to evaluate chest pain, as physical findings may be lacking. Now we will discuss important characteristics of chest pain. 1. Location. Usually chest pain of cardiac origin is central or retrosternal. 2. Nature of pain. Pain due to myocardial ischemia, known as angina, is crushing pain or heaviness in the chest. Pericardial pain may be felt as a superficial pain. 3. Radiation of pain. Anginal pain may radiate to any region between the lower jaw and the umbilicus, though typical radiation described is to the left arm. There are persons who complain only of pain in the jaw, wrist or elsewhere. When pain occurs only in the sites of radiation without chest pain, it is one of the anginal equivalents. 4. Aggravating and relieving factors. Myocardial ischemic pain in stable effort angina pectoris is brought on by exertion and relieved by rest. Myocardial ischemia means a decrease in blood supply to the heart or a lack of blood supply in proportion to the demand. Pain is persistent in case of myocardial infarction and unstable angina. Pain due to pericarditis may increase on inspiration if there is associated pleural involvement. Pain of pericarditis may be relieved by sitting and leaning forwards. Pericardial pain can be associated with pain during swallowing, which is known as odynophagia, as the inflamed posterior pericardium overlies the esophagus. 5. Associated symptoms. Excessive sweating is often associated with chest pain in myocardial infarction. Nausea and vomiting may also occur, just like in any other visceral pain. Dizziness and palpitation are other possible associations of myocardial ischemic chest pain. Now a word about non-cardiac chest pain. It is important to differentiate cardiac from non-cardiac causes of chest pain, though it may not always be possible without the support of investigations. Generally, chest pain not conforming to cardiac pain is taken as non-cardiac chest pain. Please subscribe to this channel to stay up to date with future updates. Thank you. This lecture is on breathlessness in the Cardiology for Medical Students series. Breathlessness or dyspnea is an important symptom of heart disease. It can occur at rest or with exercise. Breathlessness at rest usually indicates a more severe disease. It is the most common symptom which is used to grade the functional class of an individual. Breathlessness in heart disease often indicates heart failure, though it can occur due to myocardial ischemia, then it is known as anginal equivalent. New York Heart Association functional class is commonly used to assess the functional status of an individual. In Class 1, no symptoms or limitation of ordinary physical activity. Class 2, mild symptoms on ordinary physical activity. Class 3, moderate symptoms on less than ordinary activity. Class 4, no physical activity is possible without symptoms. Often they are symptomatic at rest. Symptoms included in NYHA class are fatigue, palpitation, dyspnea and angina. Dyspnea occurring in supine position and relieved on sitting up is known as orthopnea. Usually it's a symptom of advanced heart failure, but it is not specific for heart disease and can occur in non-cardiac conditions as well. Paroxysmal nocturnal dyspnea or PND is breathlessness which occurs a few hours after the onset of sleep, typically in the very early morning hours. It subsides spontaneously after sitting for a few minutes. Paroxysmal nocturnal dyspnea is the typical symptom of left heart failure, including mitral stenosis, which is narrowing of the mitral valve, and left ventricular failure. It may be noted that there is no left ventricular failure in mitral stenosis, though left atrial and pulmonary venous pressures are elevated, leading to pulmonary congestion. In this topic, we will discuss edema as part of the series of cardiology for medical students. Edema due to cardiac failure is usually dependent edema with accumulation of fluid in the feet and the ankle region. Dependent edema will be over the sacrum in recumbent patients. In severe cases, the edema becomes generalized with associated collection of fluid in body cavities like pleural effusion and ascites. Isolated puffiness of face is usually a feature of early renal failure. Ascites disproportionate to edema in heart disease. It is a feature of constrictive pericarditis, a disease in which the covering of the heart is thickened and often calcified. Ascites precox can occur in other conditions like endomyocardial fibrosis, which is a form of heart muscle disease. Ascites precox may be seen in severe tricuspid valve disease as well. Please subscribe to this channel for future updates. In this lecture, we will discuss fatigue and syncope as part of the Cardiology for Medical Students series. Fatigue is a non-specific symptom which can occur in multiple disorders. In heart disease, fatigue is often due to low cardiac output and may occur in heart failure, severe aortic stenosis, and mitral stenosis. Severe pulmonary hypertension may also manifest as undue fatigue. Syncope is transient loss of consciousness with loss of postural tone so that the person falls down. A less severe symptom is called as near syncope, in which there is no loss of consciousness. Syncope is due to transient global cerebral hypoperfusion. There are several cardiac and non-cardiac causes for syncope. Commonest cause of syncope is neurocardiogenic syncope, which is self-limited. Syncope can occur at rest as in arrhythmic syncope or with exertion in severe aortic stenosis. A much simpler cause is severe anemia. Syncope may be preceded by warning symptoms like blurred vision, sweating, or yawning. In this lecture, we will discuss about hemoptysis and cyanosis as part of the Cardiology for Medical Students series. Hemoptysis or spitting out of blood is usually a symptom of lung disease but can occur in certain heart diseases like mitral stenosis and Eisenmenger syndrome. In mitral stenosis, the causes of hemoptysis include rupture of bronchial varices, pulmonary infarction, and winter bronchitis. Pink frothy sputum of acute pulmonary edema has been considered as a very mild form of hemoptysis. Cyanosis is bluish discoloration of skin and mucous membranes. Usually it occurs when the oxygen saturation is less than 85%. Central cyanosis. Central cyanosis is manifest as bluish discoloration of tongue, lips as well as nail beds. Central cyanosis usually indicates congenital heart diseases, which could be congenital cyanotic heart disease or acyanotic heart disease later becoming cyanotic due to reversal of shunt when pulmonary hypertension develops. Severe lung disease can also cause central cyanosis due to poor oxygenation of blood. Peripheral cyanosis manifests as bluish discoloration of extremities with no cyanosis in the warm areas like lips and tongue. It usually indicates sluggish circulation as in cardiac failure or circulatory shock, causing more peripheral extraction of oxygen. Differential cyanosis is cyanosis of the lower limbs without cyanosis of the upper limbs. This is a classical feature of congenital heart disease with patent ductus arteriosus, pulmonary hypertension and right to left shunt across the ductus. Reverse differential cyanosis can occur in certain complex congenital heart disease with cyanosis of upper limbs and no cyanosis of lower limbs. Please subscribe to the channel for future updates. In this topic, we will discuss about palpitation as part of the series Cardiology for Medical Students. Palpitation is undue awareness of one's own heartbeats. Commonest cause of palpitation is simple anxiety. Palpitation can occur with or without structural heart disease. It can also occur due to inherited heart rhythm disorders known as cardiac channelopathies, which are the disorders of cardiac ion channels. Hyperthyroidism is an important cause of palpitation. It can be due to atrial fibrillation, which can occur in hyperthyroidism. Atrial fibrillation is an irregular fast rhythm originating from the upper chambers of the heart. Some medications like salbutamol used for the treatment of asthma can cause palpitation. While evaluating palpitation, the following features are considered. 1. Onset and offset. Paroxysmal arrhythmias like supraventricular tachycardia have abrupt onset and offset. Regularity. Atrial fibrillation is an irregular rhythm, while most other rhythm disorders which cause palpitation are regular. Precipitating factor. Palpitation on exertion and relieved by rest are likely to be due to structural heart disease like mitral stenosis. Relieving factors. Palpitation of supraventricular tachycardia can be terminated by vagal maneuvers like straining, pressure over the eyeballs, etc. Please subscribe to this channel for future updates.